Localized prostate cancer can also be treated surgically with complete removal of the prostate gland. This is called a radical prostatectomy. The radical prostatectomy involves the removal of not only the prostate, but the structures coming off the backside of the prostate called the seminal vesicles. When the prostate is removed, there are nerves and blood vessels which run alongside the prostate on each side, and these nerves and blood vessels are important for sexual function, namely erectile function. In removing the prostate, when appropriate, it is possible to spare those nerves and preserve erectile function in certain cases. One also notices when the prostate is removed surgically that the prostate is just above a muscle called the urinary sphincter. This sphincter is responsible for urinary control or urinary continence after surgery. With complete removal of the prostate, the bladder then descends or falls down into the pelvis and is connected or sewn to the urethra just above the urinary sphincter. There will be a catheter placed through the urethra going into the bladder after any surgical removal, and this generally stays in place for 1 to 2 weeks while healing occurs. There are 3 types of radical prostatectomy. The first, called the radical retropubic prostatectomy, is considered the gold standard because it is the most commonly utilized surgical approach. This involves a small incision, generally 4 to 6 inches in length, which begins below the belly button and goes down towards the pubic bone. Through this incision, the surgeon is able to remove the lymph nodes which drain the prostate and also remove the prostate in its entirety. The second surgical technique is called a radical perineal prostatectomy. This involves placing the incision in the perineum, which is behind the scrotum and just in front of the anus. The prostate is very close to the perineum, and it is sometimes easier to remove the prostate in this fashion. However, it is not possible to do a lymph node dissection through this same incision. With recent improvements in surgical technique, nerve sparing is now possible with the perineal approach, making it a more viable surgical option than in the past. The third surgical approach is called laparoscopic radical prostatectomy. Currently, this can be done in a fashion called a pure laparoscopic approach, or can be utilized with a robot called the Da Vinci robot, and this would be called a robotic laparoscopic radical prostatectomy. Through these openings, the surgical team passes the instruments that allow the surgeon to visualize and remove the prostate gland. As in the radical retropubic prostatectomy, the laparoscopic approach also allows for a lymph node dissection if necessary. The risks and complications specific to radical prostatectomy include urinary incontinence and erectile dysfunction. There are other general risks of any major pelvic surgery, and these would include bleeding, infection, fluid collections, deep venous thrombosis or blood clots, pulmonary emboli, and possibly even death. In my practice, I typically utilize the radical retropubic prostatectomy, and this is done under general anesthesia and usually takes about 2 to 3 hours. The average hospital stay is 2 days, and the patient will go home with a catheter, and this is removed in the office anywhere between 7 and 14 days following surgery. For approximately 6 weeks, activity is restricted in that I would recommend no heavy lifting or strenuous activities while the incision is healing. Urinary incontinence may occur after the catheter is removed, and this might last weeks to months. Overall, about 98 to 99% of patients are continent within 6 months after surgery. Erectile dysfunction is common after radical prostatectomy, and the return of erectile function depends on the specifics of your individual case.